The key term in this study session is antisocial behavior. Antisocial behaviors are defined as activities that disregard societal norms or standards of appropriate behavior and that violate the rights of others. They have the potential for serious harm to others as well. Breaking the law, manipulating others for personal gain or amusement, lying, lack of concern for the well-being of others or the feelings of others, and acts of violence are just a few examples of antisocial behaviors. A major subdivision of antisocial behavior involves A, overt antisocial behaviors like fighting, verbally confronting others, or B, covert antisocial behaviors such as stealing, destroying property, or lying. This distinction is related to a continuum of such behavior patterns with noncompliance and defiance located at the midpoint of the continuum. Antisocial behavior is a prominent feature in some mental disorders, such as antisocial personality disorder and conduct disorder. Antisocial behavior that is not due to a mental disorder can be a focus of clinical attention, as evidenced by the inclusion in the DSM-5 inclusion of V-codes for adult antisocial behavior and child or adolescent antisocial behavior. There is a huge number of risk factors for developing antisocial tendencies in childhood or adolescence. It is typically a combination of risk factors that best predicts the development of antisocial behavior. These risk factors can be categorized into three domains: individual factors, family or societal factors, and school-based factors. Individual factors include the inability to regulate emotion, the need for instant gratification, impulsivity, substance use, lower levels of intelligence, associating with deviant peers, alienation or rejection by peers, a seeming imperviousness to punishment or punitive cues, and low frustration tolerance. Family or societal factors include disruptions in caregiving, for example, placement in foster homes, poor supervision, inconsistent or punitive discipline styles, insecure attachments, deep family conflicts, witnessing or experiencing maltreatment, and the presence of guns or drugs in the environment. School-based factors include being categorized as needing special education, lack of attachment to teachers or motivation to achieve, academic failure, low morale among both teachers and students, disliking school and associating with deviant peers, either by choice, for example, or being grouped with deviant peers for the purposes of punishment or special education. A prominent finding is that antisocial behavior is best predicted by combinations of risk factors, including interactions between different levels of such risk processes. Moffitt summarized the work of many investigators and originally theorized that there were two courses of antisocial behavior: Life Course and Adolescent Limited. The two can be distinguished by age of onset, duration of symptoms, and types of offenses. In Life Course antisocial behavior, antisocial patterns begin in childhood, and a wide range of offenses are carried out, including victim-oriented crimes, with a high likelihood of persistence past adolescence. Adolescent limited offenses are typically related to the expression of independence and are often related to symbols of adult privilege, and there is little or no childhood history of disruption or antisocial behavior. Still, adolescent forms of antisocial behavior may be quite extreme, and recent evidence reveals that adolescent onset forms may not always desist after the teenage years. Evidence now exists for a third subtype of conduct disorder called childhood limited, in which severe early onset forms of aggression and antisocial behaviors abate by adolescence. Children with childhood limited subtype do not engage in antisocial behavior in adulthood, but often become depressed, anxious, socially isolated, and financially dependent on others as they develop. Finally, it is rare to find individuals with a sudden adult onset antisocial behavior, in the absence of earlier developmental precursors, unless drug use or head injury is present. According to recent research using self-report sources of information, 30 to 40% of males and 16% to 32% of females have committed a serious act of violence by the age of 18. Although most juvenile offenders do not commit their first serious act of violence until adolescence, those juveniles who display extreme violent behavior prior to puberty are more likely to engage in high levels of violence, commit a larger number of violent acts, and demonstrate persisting violent behavior into adulthood. In fact, childhood onset types, such as high likelihood of persistence into a life course pattern, typically show a constellation of multiple risk factors, including difficult temperament, insecure attachment to caregivers, poor verbal skills, intensive family conflict, such as family histories of paternal antisocial behavior and maternal depression, maltreatment and abuse, poor early peer relationships, and academic failure. Behaviorally based treatments such as systematic reward programs for families, cognitive behavioral anger management treatments for youth themselves have been shown effective for child and early adolescent forms of antisocial behavior. For adolescents, research has shown that the most effective treatment for juvenile offenders with antisocial behavior is multisystemic therapy, also known as MST. MST works not only with identified youth but intensively with the involvement of the parents and the family and the community. Therapists who are on call 24/7 and who work in multiple settings with the youth and family promote pro-social peer association and recreation, help families access community service-based opportunities, teach effective parental discipline and other parenting skills, aid in the creation of an extended support system, and improve performance in both school and in work. Let's practice with a question for antisocial behaviors. What is more true regarding antisocial behavior? Answer A. It is characterized by negativistic, hostile, and deviant behavior, such as actively disobeying the directions of parents or a caregiver. Answer B. It is characterized by aggression towards people or animals, destruction of property, deceitfulness, theft, and serious rule violations. Answer C. It is characterized by overt and covert antisocial behavior. And answer D. It's a prevalent pattern of disregard for and infraction of others' rights. The correct answer is answer C. Antisocial behavior involves overt antisocial behaviors, such as fighting, verbally confronting others, and covert antisocial behavior, such as stealing, destroying property, or lying. Though answer A, B, and D may be true, the characteristics may change depending on the person. Answer C is true because it is more general and true for every case. We invite you to participate in the next chapter of our series on the key term areas affected by the DSM-5. Thanks for joining us.